This presentation is on inflammation of the lungs, better known as interstitial lung disease or ILD. The lungs are about 2.2 pounds and anywhere from 9 to 10.5 inches. They're roughly cone-shaped, and the apex, which is located above the first rib with the three borders and three surfaces. The three borders are anterior, posterior, and inferior. The anterior creates a cardiac notch in the left lung and creates a pleural reflection. The inferior border, which is very thin, separates the lung from the costal surface. The posterior border, which is thick, extends from C7 to the T10 vertebra of the spine. Its composition includes the right lung, which has the right upper lobe, right middle lobe, and right lower lobe, and the left lung, which has the left lower lobe and left upper lobe. In 2017, 544.9 million people worldwide had a chronic respiratory disease, representing an increase of 39.8% compared to 1990. Chronic respiratory disease is the third leading cause of death in 2017, 7% of all those deaths, behind cardiovascular disease and neoplasms. Deaths due to chronic respiratory diseases numbered around 3,914,196 in 2017, with an increase of 18% since 1990, while total disability adjusted life years increased by 13.3%. In males and females, most chronic respiratory diseases are attributable deaths in the dailies were due to COPD. So the etiology includes lung infections, respiratory irritants, cigarette smoke, air pollution, industrial aerosols, ammonia and smoke, trauma to the lung, cystic fibrosis, or pulmonary embolism. The types of lung infections that can cause inflammation include the common cold, COVID-19, flu, histoplasmosis, pneumonia, respiratory syncytial virus or RSV, tuberculosis, valley fever, and whooping cough. There are 5 categories for the classifications. They include acute, suppurative, chronic, chronic active, and granulomatous. So the different classifications include asthma, chronic obstructive pulmonary disease or COPD, chronic bronchitis, emphysema, acute bronchitis, and cystic fibrosis. Some of the signs and symptoms include fatigue, wheezing, shortness of breath, productive or non-productive cough, easy exhaustion with physical exertion, chest discomfort, pain or tightness, cough, fatigue, loss of appetite, and unintentional weight loss. So from this image, on the right side, you can see that is normal, healthy lung tissue, and on the left side, it is inflamed lung tissue. The predominant infiltrating cell is the neutrophil, though fewer macrophages and lymphocytes may be also present. The neutrophil is also the predominant infiltrating cell type but they are aggregated, and many of them are degenerate. Cell debris from both the resident cell populations infiltrating leukocytes and proteinaceous fluid containing fibrin, few macrophages, occasional lymphocytes, or plasma cells, and possibly an infectious agent may also be present within the exudate. The tissue surrounding the exudate may contain fibroblasts, fibrous connective tissue, and mixed inflammatory cells depending on the chronicity of the lesion. For the differential diagnosis, there are a few different patterns that can be seen. In primary or post-primary tuberculosis, it occurs mainly in immunocompromised patients. The sputum smear is usually negative, often needing a transbronchial biopsy for diagnosis. With the atypical mycobacterial diseases, the nodules are often centrilobular, but can occasionally be in a miliary pattern. For viral infections, usually influenza or cytomegalovirus, chickenpox, and histoplasmosis is after healing. There is miliary calcified nodules which may occur. Fungal infections can be observed when the infection disseminates in immunocompromised patients. Blastomycosis is similar to that of tuberculosis, and then metastases is secondary to medullary, thyroid, renal, head and neck, ovarian, and testicular cancer, as well as melanomas. The less common are talcosis, which is secondary to intravenous drug abuse. The pulmonary alveolar mycolithasis is calcific nodules with subpleural sparing of the lung, black pleural sign. Sarcoidosis and silicosis, usually perilymphatic nodules, but they can appear as miliary. Langerhans cells histiocytosis is usually centrilobular nodules, but they can appear as miliary. Then bronchoalveolar carcinoma can be seen with ground glass nodules, usually centrilobular, but in case of hematogenous dissemination, they can be miliary and random. So some management and treatment include oxygen use, surgery, physical therapy, a humidifier, inhalers such as Daliresp, antibiotics if the inflammation is due to infection, bronchodilators such as ProAir, and biological medications such as Nucala and Dupixent. Some complications include cancer, which can be seen, the process can be seen in this image, right-sided heart failure, respiratory failure, and death. For prognosis, depending on the severity, it is not very favorable. When there are high numbers of CD8+ T lymphocytes in the lung tissue of pulmonary fibrosis patients, it is associated with an unfavorable prognosis. While high CD4-CD8 T cell ratio in BAL fluid correlated with better response to anti-inflammatory therapy. Additionally, in the lung tissue of patients with pulmonary fibrosis, highly organized lymphoid structures consisting of T cells expressing CD40L, B cells, mature dendritic cells were present. For current and future research, the first is the integrin. These have been implicated for a long time of IPF pathogenesis. The signaling crosstalk between TGF-beta and periostin regulating SMAD3 activity is mediated via integrin pulmonary fibrosis. Among several novel, potent, low molecular weight inhibitors capable of blocking this periostin and TGF-beta signaling crosstalk compound CP4715 attenuated bleomycin-induced pulmonary fibrosis and TGF-beta signals in IPF fibroblasts identify a novel treatable target for pulmonary fibrosis. Another is FGF2. However, in high alveolar injury patients, it is not like a likely treatment for pulmonary fibrosis. And then excessive release of neutrophil extracellular traps, or NETs, have been implicated as a fibrogenic mechanism. PAD4 is an important regulator of the NET formation. Importantly, PAD4 deficiency reduces bleomycin-induced NET formation and fibrosis in murine lungs. A large accumulation of NETs localized to the alveolar and interstitial lung compartments of mice undergoing bleomycin-induced lung fibrosis, which was suppressed by the pan-PAD inhibitor CL-amide. Global PAD4 gene knockout led to decreased bleomycin-induced NET formation in pulmonary fibrosis. So I chose 3 different quotes for my Bible integration. The first two, Genesis 2:7 and Job 33:4, was also on my previous presentation, but I felt that they were also very important to include in this presentation because they have to do a lot with breathing in the lungs. And then the 3 John 1.1.2 is, Beloved, I wish above all things that thou mayest prosper and be in health, even as thy soul prospereth. And I think that was a good explanation of what we talked about in this presentation. And then here are my references.